Welcome to Clinical Conversations' 107th podcast. It comes to you from Journal Watch, a group of clinicians and journalists who track what's new and relevant in medical research. Go to the website at jwatch.org. I'm Joe Elia. It's November 5th, 2010. Dr. Danielle Schurer of Physicians First Watch and the Medical University of South Carolina will join me today in interviewing the first author of a JAMA study examining how to prevent falls in hospitals. Before that, we have this brief message for you.
QuantiaMD and Journal Watch are pleased to present the National Case Challenge and invite you to share your most compelling case. Case finalists will be widely promoted and viewed by tens of thousands of physicians all over the world. The grand prize winner will be selected by popular vote and receive $2,500. Each finalist receives $500. To participate, visit QuantiaMD.com.
Earlier this week, JAMA published an issue devoted to aging, and one paper grappled with the problem of falls in the hospital setting. In the Boston area study, 8 medical units were randomized either to follow their usual procedures regarding fall prevention or to implement a 6-month program called the Fall Prevention Toolkit, under which patients received tailored interventions. The interventions included posters placed over patients' beds at admission and with any change in status, warning about patients' histories of falls, for instance, or their need for assistance in getting out of bed, or their mental status. Patients also received individualized handouts on preventing falls, and their interventions were made part of the treatment plan. By the end of 6 months, the program had reduced falls in the intervention units by about 1 fall per 1,000 patient days. The intervention was particularly successful in elderly patients, where falls were reduced by about 2 per 1,000 patient days. Dr. Patricia Dykes, the study's first author, has kindly agreed to talk with me and Dr. Danielle Schurer about her work. Dr. Dykes is the corporate manager for nursing informatics and research with Partners Healthcare in Boston. Welcome, Dr. Dykes, and thank you for taking the time to talk with us today.
I'm glad to. Thanks for the opportunity.
Dr. Schurer, you've got the first question.
Thanks, Joe. So, Dr. Dykes, can you give us a little bit more background on how bad the fall problem is in U.S. hospitals as far as the extent and cost of the problem? Okay, well, falls are a leading cause of death and disability in the U.S., so about a third of older people fall each year outside of hospitals. So when patients are hospitalized, it does increase their risk for falls. About 3% of hospitalized patients fall each year, and about a third of those falls result in a serious injury. So that would include like a hip fracture or a head injury, even resulting in death. So it is a significant problem. Up until recently, hospitals were reimbursed for treatments related to injurious falls in hospitals, but as of October 2008, all the costs associated with fall-related injuries in hospitals were no longer reimbursable under Medicare. So now the costs associated with falls in hospitals are absorbed by the hospital.
And in this study, I believe all the units in the intervention group were medical units. Do you think this would work equally well on a surgical floor?
Yes, we do. We selected medical units because those medical units typically have the highest fall rates, and so we wanted to take the more difficult patients and test the toolkit against them.
Dr. Dykes, I had a thought about those wall posters over the patient's beds. Is there a chance that the patient or family would object to some of those health details being posted over their heads in plain sight for casual visitors?
You know, that was the most common objection we had before we did this study, and so we did have to meet with the risk management people at all the different hospitals. People were concerned about HIPAA, and what it came down to is that information that's posted above a patient's bed, if it's needed to provide care, is okay as long as it's all right with the patient. And so what the workflow was around the bed poster was, the nurse would complete the fall risk assessment. Based on that assessment, an individualized bed poster and an individualized patient education handout would automatically print out. The nurse would go to the bedside. The nurse would educate the patient about why they were at risk for falls,
what they needed to do to work with the team to prevent falls while they were in the hospital. And at that time, they would say to the patient, this is a bed poster to remind our whole team how to help you and how to prevent falls. Is it okay if I hang it up above your bed? And any patient that said no, it would not be hung. So over the course of the study, so we had over 5,000 patients in the intervention group, and I heard of one patient who did not want it hung above their bed. Most patients want to be safe.
Were you surprised when people started citing HIPAA regulations?
Well, I guess not completely surprised. I think that it's important, when people have concerns, to work through them, and that's what we did.
Yeah.
I think that we need to be rational, though. I think that a lot of times people get so worried about regulation that we forget what we're really trying to do in the hospital. And so we really tried to stick with, we are trying to protect the patient. We are trying to improve communication. And if communication means that we need to post additional information at the bedside, the patient, people are not showing up at that bedside that don't belong in the hospital, right?
Right.
So, we did try to be rational about it. And I have an interesting or kind of a funny story. We used to do spot rounds, just to see what the adherence level was with the posters above the patient's bed. And I would go to the bedside and say to the patient, I would look for the sign, and I'd look for the patient education handout. And for one patient in one of the hospitals, I didn't see the poster, and I didn't see the handout. And I said to the patient, did your nurse talk to you about your risk for falls? And he said, oh, yes, I'm at risk. And I said, did your nurse give you a handout, some information? He said, she gave me a great handout. She even hung a poster above my bed, and it even has my name on it, and I liked it so much, I took it out and I put it in my bag because I want to bring it home to show my son.
That's
so that was
great.
one of my favorite stories from a patient. So really, patients embraced it because, again, people, when they're in the hospital and they're vulnerable, they want there to be good communication, and that makes them feel safer when we have strategies for improving communication.
Now, you studied 4 hospitals, and did you implement the plan there since the studies were completed, or no?
No, because this was done as a research project, so we implemented it in the context of research. So what we're doing is working with, for example, at the Brigham and Mass General, we're in the process of rolling out acute care documentation, and so the strategy will be to integrate fall tips into that electronic system. At the other hospitals, we had vendor systems, and so again, it's a separate process for rolling that out across the whole system than to just do a research study. So at each hospital, they are looking at how to implement fall tips. But, rolling out an intervention across a hospital is different than, within the context of a research study.
I can only imagine. What sort of resistance might other hospitals trying to do this encounter?
We encountered surprisingly little resistance, and I'll tell you the reasons. And so, number one, I mentioned earlier that as of October 2008, Medicare was no longer reimbursing for fall-related injury. So that meant, and we rolled out our toolkit, our study started January of the following year, and we were doing training right around that time. So we had a tremendous amount of support from the leadership at every hospital. They thought, it was great that this intervention was going to at least be on some of their units. And then the important thing that I think that our study team did is that when we developed the software, we worked very carefully with the end users, and we got feedback, and we ironed out any issues that we had with the software before we rolled it out floor-wide on the intervention units. And the way we did that is we used the Institute for Healthcare Improvement. They have what's called the Framework for Spread, which is a model for promoting adoption and use of new interventions or new technologies. Mm-hmm. And so what we did is we made sure that we had the right support structure. So we did have the leadership in place. We had the nursing leadership on each of the units appoint champions, and we used the champion model. So the nurse champions at each hospital were involved in end-user testing of the software. A month before we rolled the software out, we actually had the nurse champions using it only on their patients. And what they gave us feedback about what we needed to change and do before we rolled it out, system-wide, to make sure that there was nothing in the workflow that would have prevented people from wanting to use the software. The other advantage to that was that it got other clinicians asking, what is this? What are you doing? What are these signs? And then people became excited, why are you allowed to do it and we're not? So it became something that people wanted, and they couldn't wait to be able to get it too. And so when we did roll it out, we did measure adherence by doing some spot checks at the hospitals. And with the bed posters hanging above the bed, the adherence with that particular piece of the intervention was 89%. And I believe 94, or actually we have to look at the study data to have the exact, it's in the paper. But we did look at how often the nurses were actually printing the materials, and how often during the checks that we actually found the posters above the bed, and it was really quite high. And the reason was that we looked very carefully at the existing workflow before we implemented the toolkit, and we were very careful not to create new workflows, but to leverage what they were already doing. So we knew that for every patient that comes into the hospital, a nurse does a fall risk assessment, and then they redo it at regular intervals, at least every day thereafter. When the nurse first does the fall risk assessment, if they find that patient to be at risk, in every hospital they were hanging these generic high risk for fall signs. So we knew that workflow existed, and we knew that if we could have them complete the fall risk assessment, and we could leverage that information and help us to build a tailored plan, that we could probably get the nurses to do it. And our software was simple. We tested it with end users, and we just replicated the workflow that was in place. So patient comes in, nurse does fall risk assessment, but they use the fall tips. The tailored plan is automatically calculated. The nurse would review it. If they needed to change anything based on their knowledge of the patient, they could further tailor. But once they filed it, the bed poster automatically printed out, and it was to the printer that was closest to whatever computer they were working on. So it was very easy for them to then just pick that up, go in, see the patient, hang up the poster, and do their education. And they didn't see it as additional work. They saw it as making what they were already doing smarter. And so even nurses who maybe were not excited about coming into the educational session about the Fall Tips program when we first got to the unit, once they saw the intervention, clearly there really was not objection to doing it. They saw it as a better way to do what they were already doing.
So for those hospitals that are struggling with fall rates, what would your recommendation be on how to, take what you have found and start an implementation program at their site?
Well, I think a couple things. Number one, I think, in most hospitals, or all hospitals now, it's a Joint Commission standard that a fall risk assessment is completed on admission and then at regular intervals thereafter. However, what I've noticed in many hospitals, they don't use reliable and validated tools. So they use fall risk assessment scales that they either develop themselves, or they might have found one that was tested in hospitals, but then they tweak it because they don't like, different items that are on the scale. So what I would say is, use a valid and reliable fall risk assessment scale, because there is some science that goes into developing these. So at Partners in 2004, we adopted the Morse Fall Scale. That was our first step. We rolled that out across every hospital first because we wanted to make sure before we standardized interventions that every nurse was competent and assessing risk in the same way, because before you can even look at interventions, you have to make sure assessment's accurate, right? So in any hospital, they should be doing fall risk assessment, but they should be using a reliable and valid tool. Secondly, while nurses typically do fall risk assessment, what they don't typically do is create a tailored plan based on the patient's specific determinants of risk. So I would say that that's the second thing. Make sure that there's a way. So what the Fall Tips does is it uses health information technology to calculate the plan that's most likely to help that patient and to mitigate risk. So the plan should come directly from why that patient's at risk, and that's because, patients who are at risk because they're confused, the interventions you need to mitigate risk are different than what you need for a patient who might be at risk because they have a gait disturbance, okay? And then the third thing is, don't lock the plan up in the medical record because, you know what, the patient doesn't have access to that. The paraprofessionals don't have access to that. Anyone who gets to the bedside, including the patient and their family, they should have access to that plan, and they should know what their role is in fall prevention. And so once you formulate the plan, make it available at the bedside, and I do think that will protect patients from falling.
All right. Are there any online resources, Dr. Dykes, that interested people could go to, or could they get in touch with you?
Just Googling my name and JAMA or fall tips will bring up all kinds of information about this study.
Would you mind if I posted it on the website with this interview?
Nope, that's fine.
Okay. Well, thank you. And thank you so much, Dr. Dykes, for spending the time with us today. It was most enlightening.
My pleasure. Thank you.
Thank you.
Now, we look briefly at the week's clinical news so far. Undoubtedly, the week's top story has been the announcement that yearly low-dose CT lung scanning was better than chest X-rays for reducing lung cancer mortality in older people at high risk. The only data we have at present is the study's design, released online in the journal Radiology, and a news release from the National Cancer Institute saying the study had been stopped owing to the magnitude of the effect. I'll try to get an interview with the Brown University researchers over the next several days. Next, there's a new non-narcotic drug for chronic musculoskeletal pain. Duloxetine, marketed as Cymbalta, has had the indication added to its label. It already is indicated for generalized anxiety disorder and maintenance therapy and major depression, among other things. Thirdly, it's been thought that vitamin E supplements have no effect on stroke, but that's not so. It decreases the risk for thromboembolic stroke while increasing the risk for hemorrhagic stroke. Thus, studies looking at stroke effects in general found no effect, but the adverse effect on hemorrhagic stroke was masked by a partially offsetting benefit on thromboembolic risk. The authors say, quoting, that indiscriminate, widespread use of vitamin E should be cautioned against. Well, those were the three most important stories of the week, at least as I see them. For more news, go to the First Watch website, firstwatch.jwatch.org. That's it for Conversation 107. Earlier podcasts are available at podcasts.jwatch.org. Clinical Conversations executive producer is Adoriano. I'm Joe Elia. Join us next time. For myself and Dr. Danielle Schurer, thanks for listening.